Good evening. Hi, I'm Shabana. I'm one of a consultant in London. I'm a co-founder of ALMA Fertility based in London, and it's a pleasure to join you this evening with my audience and also my two expert speakers. Can I just check with the audience that you can all hear me? If you can hear me and see me, can you just write a little message because the platform that we've been using has had a few technical issues. Some people responding. Loud and clear. Perfect. Great. Okay. Well, that's a good start. So I'm just going to introduce my experts today. I have Dr. Marta Slaidina from Latvia and Dr. Halyna Strelko from Ukraine. So thank you very much for joining me today. So the conversation for this evening is ICSI, should it be included in every cycle? So just to summarize, ICSI was primarily used in order to introduce sperm into the egg, and it was introduced in order to reduce the risk of failed fertilization in couples who had male factor infertility. So a low count, low motility, and a higher concentration of abnormals in order to reduce the risk of failed fertilization the day after egg collection. But we're moving slightly more towards a more Western approach, even within the UK, where potentially a lot of cycles are now looking at doing ICSI as a first course of action, as opposed to just purely for male factor. And the drive for this is potentially to reduce the risk of failed fertilization in cycles. So it'll be really interesting to hear what our experts will have to say, certainly from Europe. So before we went online, I had a very brief conversation about the way and certainly the trends. So just for our audience, approximately 95% of cycles in the US are now ICSI. And approximately 75% of cycles are ICSI in Dubai. But here in the UK, certainly where we've always been fairly conservative. So we're looking at about a 50-50, where often the 50% of patients are having IVF only if they have normal sperm, and ICSI is therefore reserved for male factor problems. So I'd just like to ask our experts today a little bit about their practice there in Latvia and also in Ukraine, and tell me about your thoughts as to why potentially you're doing more ICSI than IVF.
Yeah, if I can start. Hello, everyone. I'm Dr. Slaidina from EGV in Latvia. We are one of the biggest clinics in Latvia, and we are definitely number one choice for patients that government covers their expenses and support patients. So approximately 10 years ago, we also had 50-50 IVF and ICSI. For patients, and then when the government started to pay for also covered ICSIs, this proportion got bigger for ICSIs, and now, for example, if we have approximately 500-600 cycles per year, then last year it was like 15 IVFs and 450 ICSIs, so you can see the proportion there. Surely, we also discuss when we should or should not use IVF or ICSI, and definitely it is connected with the quality of sperm, definitely, and of course the amount of eggs that the woman has also, and the age of the female and male partner. So, of course, if patient pays for their treatment, then they definitely uses ICSI.
Okay, so it's effectively a cost-driven exercise.
Cost effective.
For the way that you practice in Latvia. Okay, so and what about Halyna? What's your take on it in Ukraine?
Thank you. I'm Dr. Halyna Strelko. I'm working in IVF since 1999, so quite long history. And it's true that last 10 years, most of clinics doing ICSI. And mostly because on financial issue, because patients pay by their cycles by themselves. Only last 2 years we have support from government, and we receive like fixed amount of money, regardless IVF or ICSI. For ICSI they pay a little bit more, but the difference is not big. So we have just opposite situation when we compare what say Dr. Marta. Last 2 years the proportion of IVF increased a little bit, but anyway most of cycles are ICSI cycles in our country. And I think I agree with that, because the risk of standard IVF to have unexplained absence of fertilization. From the other hand, necessary to say that okay, IVF it is more natural process, and selection of sperm cell is more natural. So some patients asking about that. And also necessary to add that process of ICSI change human evolution, because in natural cycle sperm cell should move in long time and be alive on time. But for ICSI, sperm cell should move in more quickly, but okay, short time. So we choosing this sperm cell, we change evolution process.
As our embryologists say, we are cool, but the natural selection is the coolest.
Yeah, exactly.
That's why they love. We love our embryologists, but yes, they say that in IVF the stronger cell wins. So yes, I totally agree.
So I have a question for you. Are your rates of fertilization better, therefore, from doing the ICSI versus historically, if when you were doing IVF, for example?
Look, we have very good fertilization rate with ICSI, 92%, 95%, depending on months. We have every month statistics, so in most of case we have very good fertilization. So we don't change. We try to not change something which working well. And second point, that we are doing a lot of PGD cycle. And for this purpose, better to do ICSI, because before ICSI we're cleaning egg, and that's why no contamination of cumulus cells.
Okay, so you get less abnormal fertilization with ICSI versus doing IVF.
But
Sometimes we have abnormal fertilization. It's not exclude, because we can have 3 PN, we have sometimes 0 PN or 1 PN, but proportion is less than with IVF, of course.
But it's interesting.
And
we also, sorry.
Yeah.
No, go ahead.
Yeah, we also actually did PGTA for IVF embryos the last 3-4 years. It's something you can do, and we had good results. So it's also
because our genetic lab say better to do with ICSI, and okay, we don't.
Sure, and usually we also did it. If you want to do PGTA, you will do ICSI. But now this trend a little bit changed.
And are you able to tell the audience what sort of concerns often patients come with the idea of recommending ICSI? So what sort of things do patients often concern themselves with when we talk about ICSI?
As for me, my patients sometimes asking to do because okay, patients feel sometimes not very well doing IVF generally, because it is too artificial, too stressful, injections, surgery procedure. So they would like to have as minimum something natural, as minimum natural selection of eggs. So it's like maybe idea, but for patients it's quite important. Also, maybe some medical reason, because there are some publications about the increasement, not a lot, like 1%, 1.5%, but increasement of cardiological problem of children born after ICSI procedure. But from another hand, there is no a lot of uh, good study with good number of patients which compare the same age, the same sperm parameter, the same condition of pregnancy with IVF. That's why probably it is related to IVF itself, to medication itself, and not specifically of method of fertilization. So
yeah, and I suppose what I say to my patients is that it's not the actual act of doing the ICSI that affects, or certainly increases the risk of congenital abnormalities. It's actually the fact that you're creating a cohort of embryos and therefore a population of children who wouldn't otherwise exist outside of the context of assisted conception. So you're effectively passing on. If you're talking about using it in male factor infertility, for example, the offspring therefore have a slightly higher risk of having a male factor issue, and that's where that came.
We also check the echocardiograms in 20 weeks and after birth. So we do check for those risks.
Yeah, at the anomaly scan. Okay, and so here certainly in the UK, if you're self-funding a cycle, ICSI has a cost implication. So as you said, in Ukraine and in Latvia, the government are funding the ICSI. So do you think that ICSI should be included in every cycle as a default?
Very good question. Oh, sorry, Marta.
No, it's
maybe you'd like to start.
Yeah, I will just add a little comment here. I think the patient should know, and my patients always know they have what choice do they have. So even I'm also a fan of ICSI. I like it, I love it, and my patients choose it. But for all my patients, I inform them they have possibility to have IVF, and why I choose for them to do the ICSI procedure. And usually for patients that comes, of course, if there's fallopian tube factor and great sperm, great eggs, count of eggs, and young patients, yes, I can say we can try IVF. But then I say, for example, if something happens, let's go with ICSI next time. So.
Yeah, so it effectively reduces the risk of having a failed cycle, and especially because cost is often a significant factor. Then if you're effectively trying to save money from having to have to do a second cycle, then you want to optimize your chances from the first cycle by increasing the chances of fertilization.
Yeah.
Okay, so we have a question, and somebody from the audience has asked, for high DNA fragmentation as like 31%, would you recommend IMSI compared to ICSI, or would ICSI be enough? Do you do IMSI in your clinics?
We are doing a lot of things in our clinic. We are doing IMSI, we are doing ICSI, we are doing also spindle view before the fertilization. We are doing also microfluidic selection of sperm cell by, we call that sperm chip, special device, which permit to select more fast and more mature sperm cells. So for this purpose, to using all this technique, we can do only by ICSI. For example, a spindle viewer. Some eggs appear mature, but with specific device, we can see that they has no spindle, or spindle formated a little bit later, or spindle are abnormal, and sometimes we are waiting to fertilization. but necessary to clean egg to see it with this spindle viewer, and after it is impossible to fertilize by standard IVF. So for all this modern technique, of course, we should use ICSI. But what about 31% of DNA fragmentation? It depends on method, because some method give the cutoff like 26%, some of them 30, some of them less. 31%, it is not something huge. As for me, sperm chip microfluidic method of sperm selection will be the best way. ICSI or IMSI will not change a lot in this case, as for me. But okay, probably
So
you have another.
you don't think IMSI would be any more beneficial than just selecting sperm?
Yeah. And also, it is important that how many eggs, what is the age of woman, and what is the quality of these eggs? Because most of sperm damage, sperm DNA damage, may be repaired by egg of good quality. But if egg is also, how to say, poor and not very strong, in this case, it will increase this problem and increase the embryo quality. Decrease, I mean, worser.
Yeah, but I think it's also about other functional tests you would recommend for this patient, right? Like a Marta test or a Haba test. So it depends, but I definitely would suggest microfluidics for this patient, and ICSI for me.
Yeah, it's not very high percentage, and with good quality of eggs, with normal ICSI, I think will be good result. But if we will have only 2 eggs and like, I don't know, 41 years old woman and so on, okay, maybe necessary to select better these sperm cells, or maybe to do some treatment before.
Yeah, and it's when you also do ejaculation before you give sperm, because in those cases with high DNA fragmentation, we suggest to have like 2 days max, usually 24 hours.
Period. Even 1 day, maybe even like half of the day, because less period of abstinence, more young form of sperm cell will appear and less DNA fragmentation.
Yeah, and of course it also depends on the concentration of the sperm, right? So
concentration,
sometimes
and
we need to
maybe there is
choose
some disease, some problem, some infection, or I don't know, smoking or varicocele or something else. So necessary to see the context.
So we don't have any other questions at the moment, but I have a question, which is, so in your experience, do you think that ICSI can potentially damage the oocyte? So what is the risk of damage in your clinic? Or do you think there is any risk to the oocyte of doing ICSI? Because that's something sometimes patients worry about as well.
I think it can be concerns, but for us, we don't have any experience by damaging sperm. Of course, it's so many factors, and one of them is the qualification of the embryologist and the
operator. Yeah,
of course.
Yeah.
Okay, it may be. There are even some specific needles for ICSI with very thin point for fragile oocytes. And it's true that for some patients, they have very, very fragile oocytes, and maybe for these patients, even better to do IVF or doing ICSI with these specific needles. But it is not very often. Maybe, I don't know, we are doing approximately more than 1,000 cycle per year, 1,200, something like that. Maybe, I don't know, 3-4 patients per year we have like that.
Okay. So there's another question here. It says, what do you think about using second ejaculations to reduce DNA fragmentation 2 to 3 hours after the first one?
That's just we have say about a couple of minutes ago. Look, there is a problem that the DNA fragmentation may be due to some different reason. Some of them will improve after second ejaculation, but some of them not. So for some damages, like, I don't know, some external influence or maybe varicocele or something like that, yes. But sometimes this problem arrive during the maturation of sperm cell, and it will not change a lot.
Not change a lot, yeah. Okay. And Marta, do you have any opinion on that?
I think we covered that question quite recently, and unfortunately, also we have experience when we advise to to ejaculate earlier, but it doesn't improve result. So it's not for all DNA high DNA fragmentation cases, like doctor said.
Okay, so and do you think that doing ICSI reduces the risk of abnormal fertilization?
We can have abnormal fertilization with ICSI or without.
Yeah.
For example, we have abnormal fertilization with ICSI, and even after NGS, we have like tetraploidy of embryo, so it may be, and it may be due not specifically of method of fertilization, but for example, maybe some eggs may give abnormal number of chromosomal copy, for example, or we sometime to activate oocyte necessary to do something else. For example, sometimes we're using calcium ionophore to activate oocyte after ICSI. When sperm cell is not good enough to activate this oocyte. So, okay, it is not the problem of technique, it is maybe problem of sperm cell quality by itself.
Well, I think you can avoid from some unpleasant surprises if you are choosing ICSI. So basically, you will see more controlled results by doing ICSI than IVF.
Okay. Yeah, as minimum, you are sure that sperm cell is inside, and okay, if it is not, you cannot, probably something wrong with egg, probably.
Okay, so there's another question here. It says, I am considering traveling outside of the UK due to my age of 39. I mean, an age of 39, in my opinion, is not real. But she says she has a low ovarian reserve. How can I make an informed decision of which country / clinic to choose? ICSI is required, so they must have been advised to do ICSI. And how do I ensure that I choose the best clinic?
Good question.
It's always your decision. It's a decision you need to make, but you need, of course, to gather information. So how do we choose? Usually we have recommendation, right? So it's mouth to mouth, or I think it's also patients have forums where they have their experience in different clinics. Of course, usually they are sharing maybe not the best experience, and we also need to filter that. But I think also if you have some certifications, for example, ISO certification,
I think maybe patients asking whether there are certain elements of or certain add-ons that are offered in countries outside of the UK which are not offered in the UK for all sorts of reasons, whether there are restrictions or perhaps the patient's alluding to that. So if she was going to do ICSI, is there any particular thing that you could, so let's assume she's had a cycle of ICSI in the UK and wants to try something a little bit different, is there something that either of you could offer which would be different outside of that context?
As for me, I think it's very difficult for patient to take right decision about even some clinic in his own country, but in a foreign country it is mostly impossible, because even for me as a doctor, to choose a good clinic in my own country, okay, necessary that I work in there and see the result from inside.
Yeah. So it's based on other people's patient experiences and word of mouth, as you say. And I think
it's difficult. So necessary to see, for example, the statistic. If clinic give open and a lot of statistic information, if, for example, clinic doing a lot of cycles, I agree with Dr. Marta about certification. ISO certification or maybe some foreign certifications, but it's difficult.
So
I don't
she's
know how to choose like that,
Yeah, so the patients just added she had ICSI for the first round due to poor sperm motility, and then no ICSI for the second cycle. So that for me is quite unusual, because we tend not to go backwards. If you do IVF and it fails, you move on to ICSI. You don't do ICSI and then go back to IVF. But I think certainly for me, the answer to that question is that there's so much cycle to cycle variation. Even from one cycle to another, you can get radically different results. So moving to another country won't necessarily improve your outcome. But if you were looking for a cost benefit,
maybe lower cost may be the reason.
And of course, you can also choose to have online consultation prior you want to
online consultation.
So why not? So for our patient, this has been a really, really big advantage, just to connect with your patient coordinator, your doctor then. And I think even from responses and from attitude first you can also see if you want to have further relationship and to trust with your money.
In own country, since it's more comfortable, more easy, people understand how it is working. It's really
I mean, like I said, I personally think there's so much cycle to cycle variability. You do one thing, it may not be the same in another cycle, particularly if you have a low reserve, because you have a lower cohort of eggs, so a lower cohort of eggs for fertilization. Okay, so there don't seem to be any other questions as yet. Was there anything else anyone else wanted to add at the moment? So the upshot really is that this is certainly surprising for me from the UK, where we're fairly conservative and have always done a roughly 50-50 IVF ICSI. But it's really interesting to hear that so many now European countries that have a preference to ICSI from a first cycle, even in the absence of abnormal sperm. So there's a patient who's asking, do you have any advice for a 50-year-old trying to get pregnant? So just to both of you, if women are of an older age group, so let's assume that if they're sort of over 40, 42, do you recommend ICSI, or you recommend ICSI anyway? But I would say that certainly in the presence of normal sperm, I would still recommend IVF. But obviously, you would be happy with just suggesting ICSI for a first cycle.
For a woman who's 42?
Well, the lady said 50. I mean, we don't.
In this kind of cases, of course, we need to talk about the egg donors, I suppose, and then we are doing ICSI.
Yeah, I don't know. She's just any advice for a 50-year-old wanting to get pregnant, but she hasn't specified whether she
like with her own eggs.
She hasn't said. I don't
probably
know.
Probably this is about husband's age, 50 years old.
No, I think she's just.
Okay. So basically, if you're talking about a woman over even 43, yes, we need to check her ovarian reserves, but we also always inform patient about the high risk of mutation and high risk of bad quality eggs. So we need to inform patient that to get pregnant with her own eggs after 43, it's about 4 or 5%.
Yeah. So she's asking
Mhm.
she's wanting to use her own eggs with a
eggs,
young.
and through miscarriage. There was a very interesting article recently about women who would like to become pregnant after 42, and they calculate 10 IVF cycles. I don't know where they have found so many people, and so many cycles, but after 43 and till 50, and cumulative pregnancy rate for each age. And till the age 44, 45, the cumulative pregnancy rate after 10 attempts was something like 6-7%. But after was mostly zero. And also there was a publication about the possibility to become pregnant with own eggs, Israeli woman, and it was written that 0.2% of women has realistic chance to become pregnant with own eggs after 42, 43 years old. So it's possible. Maybe you will be lucky and you will have good eggs, but okay, the probability is unfortunately.
Yeah, the statistics are quite low, and that's why for women, and the question was about waiting to get pregnant. You don't wait, you act.
Yeah, necessary
And
to do
usually you
something.
act with donor eggs,
Donor
and
eggs,
then
yeah.
yes,
Yeah.
and then we
Yeah.
can discuss partner or donor sperm. Yeah.
I mean, some clinics will have a cutoff, an age cutoff, even for donor eggs, and the majority of clinics in the UK, it is actually 50, even with a donor egg. So,
yes, in Latvia, we also in our we don't have official cutoff, but we have a cutoff in our clinic, and we also have 50 years old. Yeah.
In our country also there is no official cutoff, but after 50 should be kind of concilium. So
yeah.
3-4 doctors should agree that this woman is able to carry pregnancy, because the second point, that to carry pregnancy after 50 years old, the risk of preeclampsia, diabetes arriving during pregnancy, thrombosis, premature birth, and other obstetrical problem, is very, very high. Preeclampsia is approximately 50-60%, diabetes 10%, something like that, quite high. So
yeah, and certainly that aside, if women are certainly over, let's say 55, there are some ethical and moral objections. I think some people would argue as to whether or not they should be having.
But for example, for the patient who wants to try with her own eggs after 40, we definitely would suggest PGTA, of course, for those patients.
Yeah. But I suppose just in the context of the conversation, so you would always recommend ICSI even in the older age group.
Yeah.
In this case, as for me, better to do. And also there is also article about the benefit of ICSI in younger women and more old women after 38. And it was shown that for more young category of women, the benefit is not so high, because more eggs, better quality, and even with not excellent sperm, overall result is good. But for more advanced age group, less eggs, less quality. So even additional one fertilized egg may improve their results. So as for me, late reproductive age more beneficial for ICSI than more younger category of patient.
Yes, because we also always will, not always, but usually we will get a woman with lower ovarian reserves after their 40s. So
that again is a sort of a marker as to suggest that probably ICSI is something to be
35.
considered.
I would say 35. I would say.
Okay. Okay, it's been really interesting talking because it's very different from the way that we work here in the UK. So another question, one last question. How can a patient know which clinics have the best embryologists?
I don't know. As for me, necessary to see the biography of embryologists, like publications, maybe some participations in
In
conference or some
conferences, yeah.
activity in social media, because if embryologists show a lot of interesting cases of his achievement, maybe like
I
that, I
know.
don't know, from the
I know
point
we
of view
have
of patient.
we have many gynecologists, but we have few embryologists, and they all are. I how to say they have fire in their heart for what they do. So, as I know, all embryologists, at least in our country, they are great, and I can say it also about other our concurrent clinics, because they are really, really, really loving the job they do, and they love to be in the lab.
I mean, I would say, the embryology training program is very rigorous, and patient the embryologists have to train for a number of years before they can, before they are actually, so people who, for example, donate gametes for the purpose of research, they use those gametes in order to practice ICSI and so on, PDT and biopsy. If a patient is looking for which clinic to go to for treatment, the number one thing is to look at success rates. And so, because the laboratory is paramount, the most important thing is where are my eggs and sperm going to be fertilized? Where are the embryos going to and so we know, therefore, that success rates often equate to the facilities that the lab are offering, and how the embryos and eggs and sperm are being handled. So I would assume that the best clinics have the best embryologists. Is probably the answer to that question.
Yeah. And the best embryologists go where is the best equipment. So basically, embryoscope.
Yeah, this is important. New techniques, they use new techniques, new approach. This is important. They don't repeat only routine procedure. They try to do something new.
Do you use GM colony stimulating factor this environment for embryos?
We just order 2 weeks ago. It's still not arrived, but I am using a lot of colony stimulation factor after the transfer and before the transfer, because it improved the implantation rate. I just prepared a presentation about that months ago. So it's very promising, because I compare the result of patients and egg donation program. Patients egg and egg donation program. Egg donation mostly with PGD tested embryos, and we receive maybe 30-40% improvement of implantation rate, a little bit increase of miscarriage rate. With patients eggs, it's a little bit worse, improve of implantation, but much more higher miscarriage rate, but less embryo was genetically tested. So I think the overall result is much better, but necessary to do with good quality embryos.
Yeah, because we also, I love what our embryologist said, that when we had this this fluid, this environment, we used it to grow embryos, and then they said actually it's working better when you are using it for frozen embryo transfer. So something also we discovered in the process. So basically our embryologist advised the protocol when we use this GM
this medium.
Medium. So now I can advise it to my patients. So I only advise the things I believe.
But normally you produce these substances for implantation. It's natural substance for improved implantation. It's producing naturally, so it will not be worse than standard.
Of course, but it's something you need to pay for. That's why it's not something we just add and and then at the end, the patient pays. The couple needs to be informed that it
we just have
costs
one last
something.
question again from the patient who was asking about which clinic to go to outside of the UK. So she's very impressed by the Latvian and the Ukrainian way. So she's asking, what are the pregnancy rates in your clinics for women over 40?
With your own eggs?
Yeah, I think she wants to use her own eggs with ICSI, yeah.
Well, just over 40 is good. So just over 40 is 8 to 10.
So she's 39.
But
yeah.
39.
Yeah.
It's very different. 38, 39, 40,
Yeah.
41, 42 is 39 and 42. It is like two different populations. So overall, during all year, we have around 45, 47 pregnancy rate. It is altogether. But egg donation is approximately 65. For young women, also is approximately 60.
Yeah, she's looking to use her own eggs.
Sorry?
I think she's looking to use her own eggs at 39.
Yeah. But if it is own eggs and good ovarian reserve and good quality eggs, we will have good result 39. But sometimes we have only 1 or 2 eggs and okay, quality is poor. So it's difficult to say exactly for this patient. Overall, 40 years old, 39, 40 years old, if we have good number of eggs, we have approximately 25, 27,
20.
more or less, but depends. It's very depends on quality and quantity.
Yeah, and it's the same for us because the rate of aneuploidy at 40 is about 75%. So 25% of the embryos will have 25% of the cohort of embryos will be genetically viable. So that equates to a 25% pregnancy rate at 40.
Yeah, and the patient also
42,
comments
43 will be like 5%, you know.
Yes.
It's decreased very quickly.
The patient also comments that she prefers to use her own eggs, and that's what I usually also say to the patient. Let's try with your own, and because it's the last thing and the most important thing for them to know that we have tried to do our best, and then of course we can do donor eggs.
I agree.
Sure.
Yeah. Sometimes patients need to go through that process themselves. Okay, I think that's it. Was there anything else that you would like to add?
Maybe I would like to add some words because in 1996, my Master's of Science work was genetic risk of ICSI. And it was 20 years ago. It was very new. But still, we continue to talking about genetic risk of ICSI because some genetic problem may be transferred to future generation. For example, if we have mutation of AZF locus of Y chromosome, maybe mutation of locus C, we will decrease number of sperm cell. And if we will fertilize with this sperm cell egg, and all boys will have the same problem. So still we have some genetic risk. Probably now we know that it is not huge, but some problem with sperm cell may be genetically determined. And of course, we should understand that we spread this problem in population by doing ICSI and by producing embryo with this sperm cell by this technique. So necessary to understand that. But I have discussion with one man with such problem, and they say, you have some genetic problem. Probably we will use donor sperm. And he say me, okay, if you are able to help me now, probably you will able to help my son in 20 or 25 years. So this was the answer.
Great. Well, thank you very much. I think there was one last question, and then we're going to wrap up. It says, "May I ask you what was the name of the medium that you used? I think it was GCRM, wasn't it? GCRF."
A GM, yeah. I think I also wrote it down for the patient. So
Yeah,
Okay,
it's
yeah.
written.
Yeah. Okay, perfect. Thank you very much for joining.
thank you so much.
Yeah, thank you. Thank you.
And
Have
have a
this
really
nice
lovely
evening and interesting conversation.
Absolutely.
It was really pleasant to speak with you.
because it's always really interesting to hear how people do things in different countries. So thank you very much.
Thank you.
Thank
Have a
you.
nice
Good night.
evening.
Bye.
Thank you. Goodbye.